talk about PSVT, that is paroxysmal supraventricular tachycardia. So what is it actually? It is a group of tachycardia characterized by sudden onset and termination with heart rate around 150 to 250 bpm, beats per minute. Okay. Caused by abnormal automaticity, caused by re-entry circuit, abnormal AV nodal tissue, etc. Okay, how it looks? It looks like this, comes like this. Just QRS complex, then goes down and it goes up, little bit more up, and then goes again down and goes up. This is the picture. So clinical symptoms are the same: palpitations, dyspnea, dizziness, dyspnea, weakness, syncope, etc. Normal things. Science means what doctor sees. So what the doctor sees, obviously it is a tachycardia, so heart rate more than 150 bpm. Next is hypotension. So BP, heart rate is high but BP is low. And last is big, that is Canon A waves. Most important, Canon A waves. Okay, so Canon A wave, it looks like, means if it is a normal A, then C, then X, then V, then Y. Okay, then this is a Canon A, this is a Canon A. Okay, then again normal A, C, X, V, Y. Okay, so whatsoever, three signs. Let's talk about the history, diagnostic criteria. So in the diagnosis, what I can see, I will do ECG. In ECG, what I can see is narrow QRS, a wide QRS. So what is it? Narrow QRS, as you can see, narrow QRS complex, tachycardia 150 to 250 bpm. Then P wave is absent or negative, there is no P wave, as you can see. And it is sudden onset and sudden uh, termination. So it is paroxysmal forms. Paroxysmal form, as the name itself. That's enough, I guess. On a history also, I can see the sudden onset and termination. Sudden onset and termination. Okay, triggered by we have always three things, that is alcohol, coffee, stress, okay, stress and caffeine, but not writing all of that. Investigations, obviously ECG, then 24-hour monitoring for intermittent PSVTs, intermittent PSVT episodes. Then I have echocardiography to rule out other diseases. And last is thyroid function test for hyperthyroidism. For hyperthyroidism. Now if I talk about the management, so if unstable, then I will do cardioversion. Cardioversion 50 to 100 joules. If stable, then I will do vagal maneuver, that is Valsalva. What is it? It is a vagal increase vagal tone. Okay. Then obviously in acute management, what I have acute management, I have drugs, that is adenosine. What it does, it blocks AV conduction, blocks AV conduction. If adenosine is contraindicated, if contraindicated, then what will I give? I will give normal beta blockers or calcium channel blockers. So beta blocker or calcium channel blocker. Example, diltiazem, Fedapil. Okay. Last is amiodarone drug, amiodarone for chronic management. I have beta blocker, I have calcium channel blocker. So example is obviously diltiazem and verapamil, sorry. I have sotalol for definitive management. I have catheter, lifestyle modification, that is avoid alcohol, stress, coffee, and underlying cause like treat hyperthyroidism.